Was I muted the whole time? Good afternoon, everyone, and thanks so much for joining us today for a special Instigators of Change event brought to you by Beyond Barriers, a program of Beyond Type 1. We're really excited to dive into the power of diversity in clinical research today with a fantastic conversation featuring a clinical trial participant, a healthcare provider, and an expert on diversity in clinical trials. I'm Tiana Cooks, Senior Community Manager at Beyond Type 1, where we're all about helping people with diabetes not just survive, but also thrive. I'm super excited to have you all here today, so thank you for joining. All right, so today we're going to be talking about diversity in clinical trials, and it's so important because diversity in clinical trials leads to better treatments for everyone. We'll also talk about the challenges that come from not having enough diversity in research, like barriers to care and the social factors that might keep people from participating. We'll then go over how you can get involved in clinical trials and the resources available to help make it happen. And finally, we'll chat about the trust issues around research in diverse communities and why transparency is so important in changing and moving things forward. So we're so excited. Thank you again for being here today. And just a note, our Beyond Barriers is a program that is sponsored by Dexcom. And today's event is made possible through the generous support of our sponsors, Vertex, Structure Therapeutics, and the Human Trial. Thank you again for being here today, and we look forward to an insightful and very engaging discussion.
So before the discovery of insulin, the only way you could treat a person who has diabetes, like your mom, was to put them on a really horrible diet. And so this child is 3 years old and weighs 15 pounds. Do you think you weigh more than him?
No.
Oh, you do. You weigh a lot more.
You weigh 50 pounds.
50 pounds.
It's the Flame of Hope. It was lit 30 years ago, and it stays lit until a cure for diabetes is found. So it burns for everyone around the world who has diabetes.
Jack, you know what this means if the light goes out for your mom?
It means you don't have to take your insulin anymore.
No more scary nights.
Yeah.
So that clip was from a documentary known as The Human Trial. Filmmakers Lisa Harpenter and Guy Mossman take us on a 7-year journey, giving us a look inside of how researchers and a brave volunteer are able to team up to find a cure for type 1 diabetes. The doctor also gives us a peek into Viasite, a biotech company in San Diego that developed an awesome stem cell implant designed to help produce insulin. This could totally change the game for people and help us lead towards a cure for type 1 diabetes. That would be amazing. Thank you for taking a peek at that video with us. But I want to go ahead and jump into our panelists. We have a great group with us here today. It's always such an honor and a privilege to be amongst some very, very distinguished guests. So I will start by introducing Dr. Ann Peters, who is a professor at USC's Keck School of Medicine, dedicated to reducing diabetes care disparities with over 250 publications and multiple awards. She is a leading voice in clinical guidelines and global advocate for equitable healthcare. Dr. Ann Peters, thank you so much for being with us today.
Thanks for having me.
Always great to see you. We'll hear from Dr. Ann Peters in just a bit. I'd also like to introduce Angelica Johnson, who serves as the program officer at the NIH All of Us Research Program, where she champions participant engagement and health equity. With 15 years of experience, she combines her passion for community initiatives with her culinary talents as a catering business owner and writer. Angelica is the jack of all trades. Thanks for being here with us today.
Thank you for having me.
And we also have Xavier Stills, who is a filmmaker and type 1 diabetes advocate who has produced work for artists like Little Nas X and created the NAACP nominated award short film Black Belts. His unique perspective and storytelling drive his commitment to diabetes advocacy. Hey, Xavier, thanks for joining us.
I'm so happy to be here as well. Thank you.
I need to hear a little bit more about this music, and the things that you've produced. It sounds very, very interesting.
Definitely. I'm from LA, so just very artsy, creative type.
Hey, that'll do it. Well, thanks for being here today. And last but not least, we have Dr. Charles Rickert, who is currently a professor of transplant surgery at the University of California, San Francisco. Dr. Rickert is a non-directed kidney donor, pursued transplant surgery after his experience with organ donation, completing a residency at Massachusetts General Hospital and further training at UCSF, where he focuses on transplant research, reducing bias in surgery, and ensuring equitable medical care. Thank you so much for joining us today, Dr. Rickert.
Thanks for having me. I don't make any music and I'm not a very good cook, so I feel out of place, but very honored to be here. Thanks.
Yeah, transplant surgery is pretty cool. I could barely say transplantation. Like, I think that's pretty amazing. It's hot, pretty up there. Well, thank you guys all for joining us today. We're so excited to have you for this conversation. I personally think that diversity in clinical trials is so important, and I know you can all agree with this. So I'm really excited to dive into it today and hopefully encourage others to do a little bit more research and hopefully participate in one themselves. So Dr. Ann Peters, can you just tell us what exactly is a clinical trial, and can anybody participate in a clinical trial?
Well, yes, I'll say both things, but I'll also say another thing, because everyone knows I tend to speak my mind, is that one of the things I do is to work in two different worlds. And I work on the west side of Los Angeles, where people have health insurance and tend to be well educated and sort of have access to everything they need. I spend the other half of my time in East Los Angeles in an under-resourced population where people don't have a lot of access. And for many of them, seeing us in our clinic is the first time they've ever received care. And so what my research is, and this is getting to the clinical trial, is I want to show that it doesn't matter who you are, but if you have the right access, you can do well with type 1 diabetes. And I believe that absolutely. So what a research study is, and I do all of my research in East Los Angeles, is a trial in which we're trying to show that something works. And so whether it's a pill or a device, we want to make it clear that it's worth insurance companies paying for, but more than that, that it's worth you all to use. I don't want to give you something that doesn't work. And so clinical trials are done really carefully. There's a really strict criteria for getting into one. So it's wonderful to volunteer, but just today I had a volunteer in a trial and he didn't fit in because he makes too much insulin. So it's not something wrong with him, it was that he didn't fit the criteria. And so we bring people into a trial and we do something and they know in advance, they're well informed as to what we're going to do. And then we're going to give them a treatment. And in some cases, we give them no treatment. We give them what we call a placebo, which could be a fake pill. We also say sugar pill, but that seems sort of stupid in diabetes research. But at any rate, we want to see if something new is worth it. It works better than something that's old. Or we can also do something called observational trials, which means that we're giving you something and comparing it to your baseline. So I do a lot of observational research in East Los Angeles where, for instance, I got a grant where I was able to give CGM to everybody with diabetes in my comprehensive health center, just let them use it. And then we followed them to see what benefits there were. And we saw all sorts of benefits. but we didn't want to randomize because we didn't want to have anybody without. And my problem in all of research is I hate taking things and not giving them to everybody. But research is meant to ask and answer a specific question about a treatment or device for the management of a disease, and in this case, for the management of diabetes.
Thank you so much for just walking us through that. And actually, those examples were really helpful to also consider. I know when I did my first clinical trial, sometimes you don't know, right, if you're going to get the placebo or if you're getting the real thing. But to me, that was kind of exciting. So I really appreciate you just walking us through and kind of explaining that. So back to what you were saying, like, basically anybody can participate in a clinical trial, right? It's just a matter of finding one that you kind of like qualify for.
Well, yes, and I never want anyone to feel rejected from anything. So it's not like, if you sign up for this and you don't fit, it's anything wrong with you. And in fact, the guy I just mentioned whose C-peptide level wasn't high enough, well, it turns out that he's not going to be my patient. So you don't actually necessarily gain from being in a clinical trial. You're not supposed to. But when my patients, when people come to see me, I can't help but try to help them. And so I think you learn something about yourself. And in my case, I'm kind of extreme because I'm a sucker for anybody with diabetes. But in general, they're not meant to help you per se. What you're doing is contributing to research to help others. But in the long run, for a lot of people, it's helpful to them because they get to talk to the study coordinators. They get to learn more about the diabetes. They get to learn about what the potential is. And so I have a lot of people who want to do a trial and then it ends and then they want to do another one and then it ends because they like it. They like the attention and the kind of care they get from being in a trial. But again, anybody who's interested should sign up, but they also have to look at the commitment because some trials are much more work than others. Yeah. Some trials mean that someone has to come in every other week. And, that can be a real burden. And in my East LA population, people don't want to miss work and they've got kids to pick up and family members to care for. So we try very hard to make sure that we can get people to be involved in our trials in a way that works. So we see people in the evenings, we see people on the weekends, we do house calls, we arrange transportation. We do a lot of things to help overcome some of those barriers. And that is one of the problems with doing research in minoritized populations is because they need a different kind of care than people who can take a sick day and, leave work for a day and get paid, because my patients can't. Right. So I think you've got to figure out if the trial is something for you. And then finally, and I know I could spend hours doing this, but is that it's important that if it's something complicated, like some new automated insulin delivery system, that people's families are involved, because this is something that the individual in the trial is going to experience, but it's always about the family and how that integrates into the family and the time it's going to take away and the noises and the beeps and the buzzers that might happen from the whole new system. So I think people need to be mindful. Yes, people can participate, but in general, it is something more than just one individual.
Yeah, the family support is so critical, I think, across the lifespan, the entirety of a diagnosis, right? From the time you get the diagnosis to when you decide to sign up for clinical trials and anything outside of that. So I'm really glad that you mentioned that. And I know you also talked about briefly about a couple of barriers, but I want to jump quickly over to Angelica because I know that there's research, lots of studies that are being done every single day, but I'd love to know if you could just explain some of the reasons behind the underrepresentation of diverse populations in clinical research.
Sure. So there's a lot of studies, especially in genomic studies to date, that have examined individuals mostly of European ancestry. And so it's not reflective of the diversity of the United States. And because of that issue, there may not be adequate data about genomic variants from other populations for calculating what we call a polygenic risk score, which basically tells you the likelihood of you having a disease or not. And so that historic lack of diversity in genomic studies is also a concern for other genomic related research areas, and it contributes to a concern about increasing health disparities. And so I remember there was a time I was working at American Diabetes Association. I think one of the misnomers was that people that are of non-European descent do not have type 1 diabetes as much as people of European descent, and it's just not true. But because of the studies and because there was not representation, people weren't looking at the variants that other populations may have experienced in type 1. And those are just from the research side. But when you look at some of the other barriers, they include historical mistrust due to some of those unethical research practices. And so recently, I've had the opportunity to go down to Macon County. And if you know about Macon County, you know that's where Tuskegee University is, but Tuskegee also is a town. And that is where there was a study done on the untreated study on the syphilis, on the untreated syphilis of Negro male. And so there you had a lot of people who they just don't trust medicine, they don't trust the government, they don't trust science. But we have to move away from that, because when they're not participating, there's things that we're missing that not only can help that population, but all populations. And so we understand the mistrust of the medical research that exists with many populations, including African Americans and Hispanic populations, but many other populations too. And this mistrust is just rooted in a history of, like I mentioned, that exploitation and unethical practices. And so with a program like All of Us, we always acknowledge the history open and honestly, so that we can address that first before we even tell anybody about what is research, what is a clinical trial, how could you get involved. And then some of those other barriers are lack of access to clinical trial sites in some of those underserved areas. And so we know we have some larger medical centers and organizations that are in areas where, some of the people that are hardest hit with some of these diseases and illnesses, they're not there. Simply, some people aren't a part of these studies because they're not asked to be. I hear a lot of people say, I would do that, but nobody ever asked me. And so I think it's that lack of access, lack of people, actually going to the people that it would benefit to say, hey, could you join this trial? And then there's language barriers. There's financial constraints, and then there's limited health literacy. And then one of the things that is true and near to me as an engagement specialist, as well as a program official for NIH, is the lack of engagement, primarily with minority populations in health research. And so we just want to make sure that we're not increasing the health disparities that further separates these groups from early detection and prevention, but rather we're going out and we're talking to them about opportunities for them to learn about what research is, to learn about what clinical trials is, and to learn how it could benefit them. And lastly, I'll just briefly mention a study exploring ethnic representation in diabetes clinical trials enrollment from about 2000 to 2020. And they found that 62.3% of diabetes trials under enrolled non-white ethnic groups. And so a temporal trend toward increased non-white ethnic enrollment was found in diabetes trials globally, but not in the US or the UK. And many non-white ethnic groups have a higher diabetes prevalence than white ethnic groups. And so it stands to benefit more from the results of diabetes trials. So again, that's just showing the importance of having these trials and making sure that all people are participating in these trials. And then, like I mentioned, I work for the All of Us research program. We are not a clinical trial, but we are a research cohort, and we are trying to be one of the largest. The All of Us research program is an effort to bring together 1 million or more volunteers across the country that reflect the diversity of this country. And so we are working with participants from all over the US, including our territories, who volunteer their health data for over 10 years. And unlike single research studies or clinical trials focused on a specific disease or population, All of Us is serving as a national research resource to inform thousands of studies covering a wide variety of health conditions, including diabetes, both type 1 and type 2. And so we're committed to doing better. We believe in informed participation and building trust with communities we serve. And that's one of the ways in which we'll kind of eliminate not having that underrepresentation. So that's just a little bit about what we're doing. And that's one of the ways in which we can kind of tackle having that underrepresentation for so many folks.
Wow. What do they say these days? You ate that up. That was such a good, such a good just response. And there were just so many nuggets in there. Thank you so much for just walking us through that and for the work that you're doing. I think, like you said, having those volunteers on board is so helpful to really move the needle. And I want to talk to Xavier as we're talking about, the barriers and just accessing these clinical trials. I know that you've participated in a clinical trial before, so I'd love to hear more about the clinical trial experience. Like, did you face any barriers, and what steps did you take to push you through?
That's great. I mean, I'll step in too because it's great. I think to yes and a bit of what Angelica was talking about, but I never completed a clinical trial. I went through Quest Diagnostics in order to be introduced, but I've actually never been accepted to the next level of one, which is I think fascinating. Talking to between Ann and Angelica today about what some of those barriers really are actually, because it isn't just a bit of my background as well is that not only do I was diagnosed with type 1 when I was 18 years old. I was playing football. I went from like 230 pounds to 170 in like, I think 2 months. And I just thought it's because I was getting into theater and musicals and weren't doing as many supplements. But in fact, I was type 1. And I actually had through a lot of my advocacy and panels where I talked to youth around Los Angeles, going through it, I've experienced a lot of young minority children and parents coming up to me and expressing very explicitly that I'm the first type 1 they've seen that resembles, them or looks like them and has a bit of information. And that has actually been very consistent over the past 6 or 7 years that I've been doing more of the panel work, which I think speaks largely to some of those disconnectivities and those outreach hindrances as well. I'll eventually, I guess, get to my own, I feel like maybe this panel could help me find out where I didn't make it to the next level of clinical trial, but it will be important. My other gig is that I do program coordinating at the Special Needs Network in Watts, California, specifically trying to bring resources to disabled children about 3 to 18 years old, going through trying to do early intervention practices and skills with kids with autism on the spectrum. And, a lot of these barriers we also talk about existing in those spaces as well that come back to just things that are quite literally systematic and baked into the nature and mistrust of the medical field with these communities that once they hear about the resources and we provide free resources at the Special Needs Network, they're like, this is amazing. This is great. I've been waiting for something like this. But it is a disconnectivity in them finally learning about what those things are, whether it be educational background. We have a lot of Latinx communities, so there's actually a language barrier in the administrative aspects of getting into certain trials or getting into certain resources. So, it's a bit of my experience, but it's not like there's not an interest. And I personally have seen as well, I think that there should be a conversation around incentives. I think it's also a great way to create trust. It seems silly enough, but the capitalistic aspects of medicine and some of those resources do incline people to let go of some of those trust issues a little bit because of financial restraints. But it doesn't have to be one-sided. It can be beneficial. And incentives, I think, is a conversation that we don't talk about enough when we want this information and data.
That's good. Now, when you talk about incentives too, I feel like I've seen more and more studies now that may offer a gift card or there may be a dollar amount attached to your participation. Something that Dr. Peters mentioned was that, some of the studies do require more of your time, and depending on the study will kind of decide how much of the incentives you may be given or compensation you may receive. But it's definitely something that I encourage folks to look into because, like you said, I think with more, and like Angelica said, when we don't have access or when we're not aware of something, how are we going to know to participate? So if someone was like, hey, did you know this study was available and there's, incentives involved, I think more and more people would be drawn towards participating in those trials like you'd mentioned. And I'm so sorry. I really thought that you finally were able to participate, but I'm so sorry to hear that you've actually experienced the barriers yourself into getting into those trials. And I hope that this conversation is going to help to move the needle forward.
Yeah, if anybody knows me, I'm totally down. You know, always a bridesmaid. I'm helping that data, surplus. So.
Well, I know you, so I'll make sure you get into something soon. Dr. Ricker, I know that you've done a lot to address bias in patient care. So can you share how your work on implicit bias has changed and how surgery teams treat patients at hospitals?
Yeah, thanks so much. And I just want to very briefly just thank the coordinators of the event again today for including me. It's really just hearing from the other panelists. It's an honor, and it's humbling to get a chance to learn from all of you. So thank you very much. Yeah, on the topic of bias in healthcare and in research, there's a whole lot that can be said. So I'll try to keep it somewhat condensed here for everyone. But you know, I have to say that you know, I've been very lucky over the last decade to work at two institutions, at UCSF, or University of California, San Francisco, where I am now, and Massachusetts General Hospital, that really do take a real effort to provide healthcare for all individuals. They, just like every institution, fail at times and whatnot, but are very interested in working to understand how biases impact healthcare. So I just want to very briefly talk a little bit about what bias is and what implicit bias in particular is, and how it kind of rears its ugly head in healthcare. So implicit biases are sort of defined as attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So they can really impact how an individual interacts with others, the decisions they make, when dealing with other individuals, and they're typically not aware of those beliefs that they're holding at all. And if you're interested, there is a really great book titled Blind Spot: Hidden Biases of Good People by two psychologists, Mazrin Banaji and Anthony Greenwald, that I encourage people to read if they're interested in this topic. It's really a great read. But as you can imagine, these unrecognized biases can have a terrible impact in the healthcare setting, from leading to explicit terrible programs in the past, such as the work that was mentioned regarding syphilis in Tuskegee, as well as more subtle ways in which bias has crept into more recent studies and in healthcare practices. So it's an absolute goal of mine and hopefully of healthcare in general to try to eliminate the impact of these biases. And the other very important piece of information about implicit biases is that they're very, very difficult to get rid of. They're very difficult to negate. You can do a lot of educational efforts, but typically it still fails to a certain degree to remove a lot of those biases. And so it's very important that the individual healthcare provider or investigator work closely with institutions and people outside of themselves to sort of try to keep those things in check and to try to help recognize where those things can creep in. And so, for example, at Massachusetts General Hospital a few years ago, we actually did a study using something called the implicit association test, which if you just Google search online, you'll find it. It's kind of an interesting study that looks to help you to get at what biases you may have yourself that you don't appreciate. But so we had the entire Department of Surgery do this testing to get a sense for what the degree of bias was among all of these care providers. And I would say that almost to a person, I know them, and they were very passionate about caring for patients and everything. And what we found was, maybe unsurprisingly, that the overall degree of bias was similar to the general population in the United States, meaning that there was some work to be done. But the goal of that was not to look at, not to condemn anyone's understanding or beliefs or anything like that. It was to encourage people to be self-reflective of what biases that they may have and how to combat those. And so I think really as to the question of how to combat this in healthcare, I do think that that's the first step, is sort of self-recognition of where biases can come in and how they can impact your healthcare. So you're sort of always on guard for what the impact can be there. And then I think it's an important recognition for institutions to acknowledge that sort of everyone can have, and everyone does have, certain biases. And so in setting up programs to sort of facilitate discussions on this and to have sort of review processes so that if there's concern for bias in a decision or in a clinical trial, that that there can be an open discussion about that to try to address it. And so in the area of clinical trials and the research side, I sort of it's almost like a 4-tier sort of program for how I think that we can try to combat these biases to a certain degree. As I mentioned, the most basic level is for the investigators to keep that present in their mind, even if it's not a trial that they would think of as having a component that could be tied to underrepresented populations or whatever, to always be mindful of how biases can creep in there. And then the next level is sort of the team that's doing the research. And I think it's important when a researcher is constructing a team that they really think carefully about who they include in that team, and they make sure they bring a diverse group of people in there. So you've got experienced experts on the topic, but you also have newer scientists there. You have healthcare providers, and probably most importantly, you have input and interaction from patients that come from diverse backgrounds, and to just help everyone to appreciate how decisions that are being made regarding a trial could impact those different groups. And then one level up from that sort of is the institution that's providing the funding, whether it's a company or a university, that they have in place some review processes there to specifically actually look to understand if there are any sources of bias there. And again, not in a punitive measure, but it is a goal to design an optimal project that will truly represent the patients that they're looking to care for, and that they're putting in place all of those efforts to combat the communication challenges that can exist, the historical perceptions that are justifiably in place, but tragically in place, that we've been talking about a little bit.
Yeah.
And then I think one last piece. No, I think that it's important that we always are open to sort of looking back at past studies and reviewing those studies, and not and looking at it as saying, we are hopefully in a better position now to understand where a study may have come up short in the past. And so sort of an example from the transplant surgery side is how we've historically looked at assessing kidney function and the impact that has had. And as I think many people probably know, that there used to be a race component to how we calculated kidney function. And I don't believe that was put in place with any ill intent. But what was found is over the years that this actually disadvantaged the Black American population in getting listed for kidney transplantation. And so in the last couple of years, we've actually gone away from using that, gone to a more inclusive and, quite frankly, better means of measuring the kidney function. So.
Thank you. That was so good. You guys are all just so incredible, and just information is really important. I think you bring up a good point. Like, we've heard from everyone, and it sounds like, we have come a far way, but we still have a ways to go. And I think that's why these conversations are so important. And so, Dr. Peters, I would love to know, as how healthcare providers can better support minority communities in participating in clinical trials, and are there any barriers that healthcare providers face?
So I could say 1,000 things, but I'll only say 5, although probably more. So first of all, what you were just saying about the unconscious bias we have is so true, because I raised a white child, my son, on liberal West Side Santa Monica, and life was whatever life is for that. And then I adopted a Black child, and I raised her here too. And by the way, she's a senior in college. I couldn't be prouder for her. But what I didn't understand was all of the unconscious bias that all of these well-meaning people seem to have. Not all, but I was shocked being her mother in this setting, because the world was so different to my Black child than to my white child, just because of race. It had nothing to do with who they were and who they were with or whatever else. It was so eye-opening. And I also understood that I can't understand what it really means to be Black because I'm not. And it's not that I can't be taught, and Skylar taught me more than I'll ever have taught her, but that when I do research in any community, I do it for the community and with the community. And so my program in East LA is embedded in a comprehensive health center. So my researchers are within the center. We've been there for 20 years. We've engendered the trust of the community. All of our research involves focus groups, community participatory events. We have all of the people who work for me are from the community. They speak Spanish, native Spanish speakers. And the people, it's a world in which someone of color doesn't feel like they don't belong. It's made for them. And the other thing is that I won't even name names of other institutions in town, but they know that I have access to all these patients, and everybody wants to come and do research at my site, which means, and I don't say yes, taking their protocols and their information. The handouts and the consent forms and everything are at an 11th grade level in English. And they say, oh, we'll translate them into Spanish. And I say, no, you have to change them into Spanish. It has to be simple. It has to be words my patients can understand because their literacy levels are lower. It has to be procedures and protocols that they can follow. They can't come in exactly every 2 weeks because that's not their lives. Their lives are much more volatile. They may have to go work one day and not another day. There are so many different realities. And you have to understand the community, the people, the family, the needs. And I think that people who write these NIH grants, something against the NIH, say, oh, we'll include, 20% Latino people or 20% Black people, whatever. But they have to create an entirely different structure for that trial because it has to include what those people need. And it makes me a little bit crazy because I don't think it's not demeaning, it's just understanding. And people don't understand when they're trying to do research that there has to be more than one way to do it. So I need more time. I need more time to translate everything into simple Spanish because my patients almost all speak Spanish. I have to have more time to do consenting. I have to have more time to do nearly everything to make it fit the needs of my patients. Mm-hmm. And I can't make them into literate, college-educated white people. That's not who they are. So you have to make the research fit the people. And you have to engage the population, and you have to engage their trust. And when I first started doing research in Watts, I said, we've got these great projects and blah, blah, blah. And they said, why should we trust you? You just come in, do research, take information from us, and then you leave. And we're not any better off for it. We're giving you our health. We're giving you all of this data, and we get nothing back. And so I said, trust me, I'll stay. And I've stayed for all these years. And most of my research is in East LA, but my first research was in both. And I really believe that you have to do what I'm saying. And if you don't do it, you're never going to include people because it doesn't feel right if it doesn't feel like you're in an environment that's made for you. And I just think we make environments for people who are going to do research that are, fancy white hospitals with, again, this higher literacy information. And that's not how my patients are. So that's my very long answer. But I feel so passionately about it because I would feel funny going into a place where nobody understood me. If I don't even like it as a patient anywhere. And so I think we need to train more doctors who are from minoritized groups. I think we need to actually get staff. And we have the best, in my group, we have the best retainment of patients. We don't lose patients. Patients bond to us, a couple hundred people, and they don't leave us because they know they're treated for who they are. Anyway, sorry.
Okay, you're gonna make me cry because, like, why can't we have 1,000 of you? But also, you bring up such a great point about the importance of meeting people where they're at and really catering to different language barriers. It's more than just, what we're discussing here today. I think when you really peel back the onion, we'll be able to understand that, in order to have that trust and to build that trust in these communities, you really have to talk the language. And I really appreciate you for mentioning that. Angelica, I know while we're on this topic, how do you feel we can better educate our communities on the importance and safety of clinical trials?
Yeah, so first I just want to bridge a gap to something that, and I really love what you said about, working in communities, making sure that everybody that's working in those communities are reflective of that community, that some of those folks speak the language. And if I hadn't mentioned it, the All of Us research program is what we call a precision health initiative. And so as an engagement specialist, one of the things that I am very passionate about is what I call precision engagement. And what I also like to add to that lens is precision communication. And so when we talk about better educating our communities and the importance of safety and the importance of representation in those clinical trials, I think at first we have to do what's important to them. We have to meet people where they are. We have to talk about things that are important to them. We have to meet them in spaces and places when it's not just beneficial to what we're looking to have done, but focusing on what's important to them. And so for me, in my work, I'm always looking at what's most important to them and how can I infuse the message of precision medicine. And so for me and my family, Alzheimer's disease is something that's very important to us. And how could I relate to my family, a family of color, the importance of all of us participating in something so that we can either figure out what we need to do so that we don't experience what other people in our family have. And so you're like, how do you do that? And I've been working in health for about 20 years, but it's very hard to talk to my own family. And so some of the things that I found, not just through my work, but even in my personal experience, is having those targeted community directed programs, essential tools for reaching communities that have previously been excluded. And I will tell you one thing, I've worked at the American Diabetes Association. I had the honor and privilege of being the associate director of type 2 diabetes programs. And one of the coolest things that I've gotten to do on the planet is to tour the country, a 26 city play called Mama's Girl, Sugar Ain't Sweet. And it was really about type 2 diabetes management and prevention. And so this play of sorts, this theater play, it targeted African-American families across the country, because when we think about meeting people where we are, like you mentioned, everybody is not met with, it's not positive when you give somebody a flyer and say, go read this. And, if you learn about type 1 diabetes and everything about it, then you'll be a professional and you'll know a lot about your care. That's not true. People, everybody learns differently. Different communities learn in different ways. And so I think it's very important that you do know your audience, that you do know the different communities that you're serving, the different communities that you want to participate in clinical trials, so that you understand how to engage them. And engaging them looks a lot differently in different communities. And so I think also being committed to what that looks like, because I think a lot of us, especially in the health profession and all professions, we want to do what's right. We want to make sure, even in sales, the customer is always right. But sometimes we have to ask ourselves, are we willing to do what it takes to do that? Like in some communities, it's literally going to take me to do more than just going to a health fair and passing out flyers, or having, medical staff with me, checking people's A1C and things like that. It's going to take more. And so I think the other piece of that, and Dr. Peters, you said it so nicely, partnering with trusted community leaders and organizations, working with faith-based organizations and churches, temples and mosques, wherever people are going, diabetes support groups, to make sure that we're also sharing accurate information, especially when it comes to clinical trials and people's safety, promoting the transparency of safety measures in modern research and trials, including participant protections, data privacy, and ethical oversight. So many people, especially with our program, it's interesting. We always are thinking about, keeping their biospecimens and their name from being identified. And so many people, while they think that's important, some of the questions are just, I've seen on TV where people come and the cops say, "Oh, we found such and such." Sometimes it's just explaining it to them in a way where they understand. Oh, yes, if you saw that on television, we would not be able to do things like that. Like, I think in just meeting people where they are, and then again, using those real world examples, even to show how diverse participation in trials has helped develop diabetes treatments tailored to individuals with type 2. And so of many different ethnic backgrounds. And I'll just say that we as a program, we have been doing a lot of informational sessions to address some community concerns around clinical trials and outcomes, especially with people with diabetes. And we've had a lot of people looking at diabetes in our data set. And one of the cool things that they did was use the Fitbit data set and looking at type 2 diabetes and diagnosis over time. And just looking at if a person takes at least 10,700 steps, which is that's something that a lot of physicians encourage people to do, it's linked to lowering the risk of type 2 diabetes. So just looking at things like that, where people don't look at that, not necessarily a clinical trial in the way of thinking, but it is a study that people are doing. And it's actually showing that by doing those things. So if we have more participation from people who are representing all of those different backgrounds, imagine what that could do. Imagine having wearables data for Fitbit from diverse groups of people that can help increase what we know about fitness and health. So I think it's just very important about how we go and address communities. Again, you have to get out in the community. You have to be committed to what the community is interested in. I think, far too many times we go in with our own purpose. But I think if we're open to it, we'll go in and we'll find that we'll actually learn a lot more. And together with community, we'll discover way more than we would have if we've done it by ourselves as a scientist, a researcher, a doctor. So yeah.
That was so good. I think when you say get in the community, like that should be like the banner. Like, I just feel like that's so important. And it's nearly impossible to understand something when you don't actually kind of put yourself in that environment. And so I highly encourage, if there are any, people watching this, healthcare providers, and you want to learn just a little bit more about maybe some barriers or disparities that those communities are facing, like you said, just get into that community. And I think that's also how you learn to speak the language, like we've been talking about, right? That was such a powerful point. I know we've got about 10 minutes left, and I have so many questions for you all, but I want to jump over to Xavier, and I just want to know, like, how can participating in clinical trials make a difference for people with type 1 diabetes, and what benefits have you seen? Oh, snap. Are you muted?
I am. I'm slightly freezing. I apologize. It is cool 100 degrees in the Los Angeles Valley right now. If you can't tell, these are not blood sugar sweats. I think with any information, back to I think what we are all talked about a bit, all information is helpful. I remember I was an assistant program director for the Science Entertainment Exchange early in my career, and we had a meeting with Johns Hopkins University early on in the COVID-19 pandemic, and they were creating a map that was trying to essentially figure out what was going on. Why is this disease core in certain areas? And they talked about it specifically with their board that they were circling all these issues. They couldn't figure out what was happening, and then they added color to the map. And that immediately helped them create idea and a nucleus of what was going on as far as disparities in medical fields and health. So a lot of these things that come up are really like comorbid issues. Information is so important. So I think that breaking down these barriers and getting a comfort level and creating these structures where data can be utilized and obtained in a trusting way that addresses some of these more comorbid issues and holistic like things will be what it takes. We're blessed enough at Special Needs Network where we're next door to Charles U University, which historically is a minority, focused like health sciences learning universities. So we are able to create a lot of research through them, but that back to community and trust, they've been in the Watts Willowbrook community for forever. And that makes it a lot easier for Pipeline, for us as a very minority-based organization, to be able to give them the files, essentially, to hand over those information, create those programs, and I see the benefit every day from it. And, so really it's obviously a bigger issue than, we can solve today, but really creating those community pipelines and actually addressing some of those translation barriers really will change over time, because once the community does have the ability to know that they can go to somewhere where they can maybe get an incentive and trust, then we get the data, and that data maybe helps us. It all comes full circle. We're really just talking about breaking down systematic issues that have been in place because they're systematic. So yeah, that's kind of my two.
Thank you. Yeah, I mean, it sounds like you all are just doing such incredible work. And I think something that we maybe haven't touched on just yet is that sometimes people might think of a clinical trial and get a little bit scared. I know all of you have, experience in the communities, and you've talked to these folks. And I know for myself, at least, when I first heard of the word clinical trial, I was like, that sounds crazy. Like, what are they going to do to me? How long is this going to take? Is the process going to hurt? Like, I wasn't sure exactly what was going to take place. And so, as you mentioned, Xavier, like, it sounds like you guys are doing things not only to build trust in the community, but also to make it kind of fun, and also reassure people that it's important to participate in these clinical trials. And they're okay. Most of them, if not all of them, are very safe for people to participate in. Dr. Rickert, what can be done, in your opinion, to make clinical trials more diverse and fair for all participants?
Yeah, well, I think that, so many important points have been touched on. I think, some of it goes back to sort of what I was talking about before, about trying to overcome some of these implicit biases. But then I think there's so many structural elements that that we have to overcome. Healthcare and clinical research is not done in a vacuum, and so the barriers that exist in healthcare exist in so many other areas that impact the healthcare and clinical trials. And this is, I guess, just a little bit giving some insight into my overall philosophical approach or something like that. But I mean, for instance, for healthcare, I personally think that we need to change the discussion, and we need to see healthcare as a right, not as a luxury that you have to pay for, because there are so many barriers to achieving financial stability for some populations, that just compounds the challenge of the healthcare as it is right now. And so I think we need to work to sort of just disengage healthcare, as we had previously had some success with education and public education in the past, although that is getting more challenging in some ways. But really to remove that from some of those other barriers that are in place. And I think that's the same when it comes to clinical trial work, to try to identify all of those barriers that underrepresented populations are dealing with, the perceptions and communication barriers, those financial barriers that exist. And I think that what's, from a sort of a structural standpoint for clinical trials, I think it's really important to really advocate that their team makeups, as I was mentioning, are really very diverse. And I think this goes along with delivering of healthcare in a welcoming fashion, is to have the care delivered by individuals that come from the communities, that have had, have some shared history with the groups that you're trying to treat. And I think that another component is to really promote clinical trials to be as much as possible multi-institutional and nationwide, and work with groups like all of us to really get access to a really incredibly diverse group of patients. I think that if you're only looking at the patients that typically come to your hospital or that live in the area around the institution where you're doing that care, you're going to miss out on how a disease is impacted by rural communities, how it's impacted by inner city communities, how it's impacted by people that are potentially non-English speaking or recent immigrants. And so I think that trying to really cast a broad net there, and for the institutions and the studies to really take a collaborative approach to not only working with other institutions, but working with groups of interested and sort of like-minded, and I shouldn't say like-minded, but work with individuals that have the same goal of conquering the disease and helping as many people as possible.
Yeah, great response. And again, another way to just continue encouraging folks, and especially healthcare providers, to cast that net wide, just like you said. And I like how you also mentioned the importance of having all of those different people sitting in those chairs, sitting around that table, making those decisions. I think that's so important. So we have 4 minutes left, and I still have a million questions for you guys. And I'm so bummed because I wanted to get to every single question here. But I'm going to just ask a couple more before we head off for the evening. Dr. Peters, I just was going to ask you, what role do innovation and new treatments play in managing type 1 diabetes?
Oh, I think so we don't have a cure, but
Right.
There's a huge role for innovation, and there's a huge role for individualizing care. So I'll do anything that's safe, that works for a patient, and it has to be right for that individual. But for instance, I mean, many of my patients use Loop or IAPS or some of the newer ways of the open source automated insulin delivery systems. I've long been using GLP-1 receptor agonists in people with type 1 who need it. So I think that there's research, and that's being done. And then there's approved treatments that we can use, if safely, in patients off label, because that's not illegal as long as the person knows they're off label. So I really try to figure out, this is a human in front of me, these are the tools I have, and how can I help treat this better? And then the clinical trials work is all meant to then further that. So I work with a company called Vertex, and they're doing trials and looking at islet cell transplantation, but now trying to look at it without using immunosuppression, which would be the holy grail for doing this. And to me, it's really exciting to see and to actually work with transplant surgeons and to start seeing, what's possible. And I've never actually felt there was more energy than now in terms of what we're doing to move forward. And I'm not so sure that we're going to cure type 1 nearly so much as we may treat it much better. And so if you have to get a treatment once a year, that's going to be infinitely better than having to deal with it on a day-to-day, minute-by-minute basis. And then a cure, I'm not even sure what that is. But all of this is possible, but certainly better ways to treat it are much closer.
Well, I'm sure there's a cure on the horizon. Right
now, so you can be cured. But no, I mean, I don't know. I think we need to ask for the right thing. And I think that what we want and what research is moving towards is doing much more like a cure. But I think that even for being quote unquote cured from type 2, there's always this risk. And I think one always has to be mindful of risk, not just about glucose, but of other things. And I just want everyone to understand that health is about taking care of ourselves. And I'm a big believer in lifestyle, and I don't care what you have. And, it doesn't matter. Lifestyle makes all the difference for dementia, for heart disease, for cancer. So I just feel like we're never going to get away from that.
Thanks for keeping it so real with us. I agree with you 100%. Other than the cure piece, I'm still hopeful. And I'm like, that's why we got to participate in these trials, because it's important, right? This is how we get the research that's going to hopefully eventually lead to those treatments, like you said, where you only go in for like one intervention a year and you get something. I don't know what that looks like, but we have to do these trials. It's so, so, so important. My last question for this afternoon, Xavier, it's for you. I just want to know, and this is a safe space, what do you think organizations like Beyond Type 1 can do to better connect with Black and Brown communities with the opportunities that offer clinical trials?
Oh man, it's always great to wrap everything up. I hate to sound like a broken record, but it really is to be in those communities. It's the only way to do it. And presenting the information, there is a lot more positive response out there, I think, once it's presented to the people who need the resources and who would benefit from it, whether it be short-term or long-term. But it's simple. I think I brought it up there. Just, like, I can only speak for South LA because of the research I do there. But Type 1 has also expanded very heavily into the social media verse as well. So there is there are large social media platforms that I will say, as opposed to some other diseases that are very community driven. Whether that be for survival or not is another conversation for another time to find certain resources. But they're expanding and they're showing the diverse pool more, I think, than some of our local organizations may be able to tap into. And I think that should really start to be looked at a lot more, which is probably the most millennial thing I can say. But I think that even widening our base and realizing that disconnectivity is an issue happening in institutions, well, we need to nuance how we are finding these groups and introducing ourselves. That is the overall goal, to create that trust base.
That was so good. And just to circle back, this Beyond Barriers is a new program that Beyond Type 1 recently launched. And I think the most exciting thing about it is, like, this is our best way of getting into these communities and being on the ground. I would love if everybody here could take this brief survey whenever you get an opportunity to do so. But thank you all so much for just joining us today, for your vulnerability, for your expertise, for offering your time and your energy. And thank you to everyone who tuned in. I know these conversations aren't always the easiest to have, but they're so important. And I hope that we've touched at least someone today and encouraged somebody to participate in a clinical trial. This is how we change the world. This is how we make an impact in other people's lives. And so always be reminded that it's bigger than you. And so thank you, Dr. Peters, and Angelica. Thank you, Xavier, Dr. Rickert, for just giving us your time this afternoon. And thank you to our sponsors, Dexcom, for making this conversation possible. For those of y'all who are listening still, you can join the movement and help save lives. Become a See the Signs ambassador at https:/beyondtype1.org/see the signs. All right. Well, thank you all so much, and we'll talk to you soon.
Bye.